So before we go to the ascending system, just want to quickly highlight how this knowledge is going to help you to localize. So for example, if somebody has got weakness of both the lower limbs, where do you think the problem is? In the motor pathway. So just the lower limb are affected. The upper limbs, no cranial nerve. So where is the problem in the whole motor pathway? Spinal cord. It has to be in the spinal cord. Rarely it can happen in anterior cerebral artery stroke, because sometimes one anterior cerebral artery can supply the medial side of the brain instead of two separate artery. In rare occasion, one can supply both. Okay. In that case, but in all practical purpose, it is usually in the spinal cord. If somebody has got all four limbs affected but no cranial nerve affected, where is the problem? So all four limbs, upper limb, lower limbs, but none of the cranial nerve is affected.
Still in the spinal cord, but a higher level.
Higher up, around the cervical, because that's where the upper limb fiber. So it is in the cervical, but below the brainstem, below medulla, definitely. If all four limbs, along with cranial nerve sign, where is the problem? Has to be brainstem. Has to be brainstem. Okay. Has to be brainstem if all four limbs. Now, if there is one-sided involvement, where could be the problem?
Like the contralateral cerebral cortex?
It could be in the cortex, it could be in the centrum semioval, it could be in the corona radiata, it could be in the internal capsule, it could be in the midbrain, it could be in the pons, it could be in the medulla until it decussates. Okay. Now, how can you differentiate whether it's in the midbrain, pons, medulla, internal capsule, or higher up?
Like a specific signs?
Yeah, so depending on, if it is in the cortex, you expect other signs of cortex. If it is in the midbrain, you expect other signs along with that. So that's how you can only differentiate. Okay, that's the only way you can differentiate where. So that's how you can localize step by step. So as soon as there is weakness of one side, as soon as there is weakness of all four limbs, you have got only two choices, either in the cervical or in the brainstem. There is no other place where it can cause it. Okay, and so if they have got cranial nerve symptom along with that, then it has to be in the brainstem, and it has to be usually, if it is a stroke, basilar artery, because it supplies on both sides. Okay, so that is the way you localize. And sometimes the extrapyramidal, for example, you can get movement abnormality if the rubrospinal is affected sometime along with that, which gives you a clue. So all these are, you can have the associated signs. So for example, if somebody has got weakness of the right side along with third nerve palsy on the left side, where do you think is the problem?
Would that be a lateral medulla?
Not lateral,
Medial.
medial medulla, not medulla. How medulla? Medial midbrain, because third nerve is in the midbrain and the pyramidal tract is going, so both are affected. So it would be third nerve on one side, motor tract on the other side, because that motor tract decussates at the lower part of the medulla. Okay. Similarly, if there is only dense weakness and sensory impairment without any higher mental function abnormality, where do you think the problem is? Internal capsule, posterior limb of internal capsule. Okay, so that's why you can specifically say, if somebody has got, for example, motor weakness, but they have got increased tone, very high tone in the outset, always think of basal ganglion. So these are the clue how you can quickly say where is the problem. Okay, these are the clue which will give you an answer. Okay, If somebody has got weakness of the upper limb more than lower limb along with some other higher mental, like for example Broca's dysphasia, where do you think the problem is?
The medium. Like that.
So it would be more in the cortical problem, okay, because they have got Broca's, that's the frontal lobe, plus they have got weakness, and it's in the medial, it's in the middle cerebral artery territory, so it's more higher up. So depending on the associated symptom, you can get an answer and it will help you to localize. That's why it's important to know this pathway, okay. That's why it is very, very important. If somebody has got, for example, midbrain sign and they cannot mobilize at all, that means the central pattern generator is affected, which is in the midbrain. We see sometimes patient they cannot mobilize at all. I still remember a patient who had the midbrain stroke and she couldn't mobilize at all. That's because this central pattern generator for locomotion was affected. Okay, so that's how you get a clue step by step, and that's what helps to localize. Similarly, knowing the pathway of the ascending system will help you to localize, and we will discuss that. But before that, let's look at the ascending pathways. What are the important ascending pathways?
Dorsal
Yeah.
and spinothalamic.
So dorsal column, spinothalamic. What else? So you might have noticed I've done a lot of handwriting because I don't want to get into copyright put in YouTube. That's why all the drawing I've drawn myself, just because you never know, somebody can put a copyright problem in YouTube. So so what are the pathways? So that's why it's all, some of them are handwritten. Although this won't matter, but I just wanted to. So spinothalamic, then dorsal column. It's not dorsal spinothalamic, it would be dorsal column. Then spinotectal, dorsal spinocerebellar, ventral. So the most important pathway which you have to know is the dorsal column, spinothalamic, and the spinocerebellar pathways. So when it comes to the receptor, dorsal system or dorsal column, what sort of information do they carry?
Is it
Fine touch, vibration, and proprioception. And what does for the Meissner's and the Pacinian corpuscles carry fine touch and vibration. And for the proprioception, Golgi tendon organ and muscle spindle are responsible for carrying it. Okay. So Meissner's and Pacinian corpuscles carry fine touch and vibration respectively. And for the proprioception, Golgi tendon and the muscle spindle are responsible. For anterolateral system, what are the information do they carry? Pain, temperature. Pain by the free nerve ending and thermal receptor. Out of the pain, A delta pathway for fast pain. Okay, so if you touch something, immediately you feel, because that is carried by the fast, so they are a bit more myelinated. And C fiber for slow pain, which is unmyelinated, so that takes longer. Now, fast pain ends in ventroposterolateral nucleus. That's why you are aware of it. Slow pain, they go through the reticular formation. Okay, so they make you feel uncomfortable, but not always you can exactly localize, and they are longer. They takes longer. And you are all aware about the gating pathway. How is the pain controlled in gating pathway? So there are neurons which goes down, especially from the periventricular and periaqueductal raphe nucleus, and they secrete endorphin to stop the information going up, and that's why you can reduce it. Okay, and probably in hypnosis this effect happens because consistently in patient you'll see I've hypnotized for something else, and they said surprisingly I had a back pain. I remember, like, it has happened so many times. I had back pain. When they come out of the hypnosis, that back pain is gone. Okay, because of this gating theory. Probably they secrete this endorphin into the.
Is that the same as the spinothalamic or the anterolateral?
So this is for the anterolateral system, not for the. This is for the pain specifically.
Oh, just for pain.
Just for pain.
Right. Okay.
So remember, dorsal column, they enter the spinal cord. They do not relay. They do not relay. They go up. And where is their first relay? Unlike the spinothalamic, they don't relay. So they go up at the same level. Say they go up without crossing and they relay in. So they relay in the lower part of the medulla. Okay. And what nucleus do they relay? And cuneatus. Okay. So gracile for the lower limb fibers and cuneatus for the upper limb. And then after they decussate, they form, what is that called? The fiber going up is the medial lemniscus. Medial lemniscus. Any of these, when they go to the brainstem, is the lemniscus. So it's the medial lemniscus. On the other hand, and then after that, they will relay in which nucleus of thalamus? They will go through the posterior limb of internal capsule and relay in which nucleus of thalamus?
The VP.
Ventro-posterolateral nucleus of thalamus. Okay, so they will relay in the ventro-posterolateral nucleus of the thalamus, and from there they will go into the parietal lobe for conscious awareness of that.
Can you just keep the thing for a second, please? Yeah, thank you.
Next is the anterolateral system, or what we call the spinothalamic system. Unlike the dorsal column, here the fiber will enter, but they will relay. And once they relay, they cross midline. That's the usual in the ascending pathway. As soon as they relay, they cross midline. So that's why the dorsal column, as soon as they relay in the medulla, they cross and went on to the medial lemniscus. They cross. Now when these fibers are coming, they can relay at the same level, or they can go up or down to relay. Okay, they might not relay at the same level. So that's very important to know. And as soon as they relay, they cross and then they will go up. But when they are relaying and crossing, they can produce anterior as well as lateral spinothalamic tract. Okay, and then they will so the anterior is responsible for crude touch, and the lateral spinothalamic tract is responsible for pain and temperature. Fine touch by the dorsal column, crude touch by the spinothalamic system. So the anterior spinothalamic tract will take the crude touch and the lateral will take pain and temperature, and then they will join in the brainstem to form the spinal lemniscus. And where will they go and relay? Ventro-posterolateral nucleus of thalamus. Okay, and then eventually they will go to the cortex. But for pain pathway, this lateral pathway, it's a bit more complicated. Why? Because pain is more complex. Okay, so as they are going up in the brainstem as spinal lemniscus, they stimulate the reticular formation. So if somebody slap you, do you get more sleepy or do you wake up and get angry? That's because the reticular formation is activated. That stimulates the limbic system. That's why you get emotional as well. On top of that, it also goes to the cingulate gyrus. Okay, that's the part of the limbic system. That's why you get angry. You get it like it's stimulating the limbic system as well, along with the reticular formation. Reticular formation is one of the function is obviously make you more awake, arousal system. So that's why you get, you know, if somebody slap you, even if you are feeling sleepy, what will happen to you? Wake up, okay, and get more alert. That's because of that. And obviously it is also part of it will stimulate the limbic system along with cingulate gyrus, and part of the fiber from the thalamus, apart from going to the parietal lobe, also go to the insular cortex. How does it help? By the autonomic response. That's why when patient has got pain, their pulse rate can go up, and that's one of the indicators. If there is, you know, even if they are not able to say, if their pulse rate or respiratory rate is going up, you suspect that they might be suffering from pain. Okay. Spinocerebellar, there are two groups. One is the dorsal spinocerebellar, another is the ventral spinocerebellar. Dorsal means behind, ventral means front. The dorsal one, when they go, they cross. Okay, they will cross, and then they go. Their pathway is more complicated. Let's go to the before going to the ventral one. Let's go to the dorsal. Dorsal one, they will go relay, and then they don't cross, and then they go straight through the inferior cerebellar peduncle. They will go onto the same side of the cerebellum. Okay, so the dorsal will go to they don't cross, they go straight through the inferior cerebellar peduncle and go and relay into the cerebellum. Did I make a mistake in dorsal and ventral? So dorsal one, like the dorsal column, they do not cross, they go straight, but they will, in case of the dorsal column, they go and they relay in the medulla, they cross, so they go to the opposite side. But here they will go and relay on the same side of cerebellum. For cerebellum, ultimately it's always the same side, but for ventral it is bit more complicated. So the ventral will first of all cross. Okay, so if they start from the left side, they cross to the right side. They will go up through the superior cerebellar peduncle. They will go to the opposite sided cerebellum. Then they will cross from one cerebellum to another through the superior cerebellar peduncle, reach the opposite side. So at the end, it's still reaching the same side, but via a bit more complicated route. Spinocerebellar tract, both ventral and dorsal, will go in the same side. It's always the same side. For the dorsal, it is going straight through the inferior cerebellar peduncle and going and relaying into the cerebellum on the same side. For the ventral, they will cross, they will go to the opposite sided cerebellum through the superior cerebellar peduncle and then cross again back to the same side. Okay, but ultimately it is on the same side. Is that clear?
But they will cross through the cerebellum.
Yes. So they cross first of all in the spinal cord,
Yeah.
and then they go to the opposite sided cerebellum through the superior, and
Yeah.
then they again cross
Yeah.
and come back to the same side cerebellum.
Yeah.
I don't know why that happened. Like, why do they need to do this, go this, go this? Why didn't they go? I've got no clue. There must be some sort of reason. So the ascending tract, we have said, the major tract, what we should know is the dorsal column, the anterolateral system, out of which, so the dorsal column, they don't cross the midline at the level of spinal cord, go to fasciculus gracilis and cuneatus, through the then they go to the through the medial lemniscus, ventroposterolateral nucleus of thalamus, and then they go to the cortex. Whereas the anterolateral system, the lateral one is carrying the pain and temperature. Okay, they immediately cross, and then they will go up straight to the thalamus, and from there they will go to the different part of the cortex. On the way, the lateral stimulate the reticular formation. Whereas the anterior, which is responsible for, what do they carry? The crude touch. Okay, so they are slow, and they again go to the same way, to the ventroposterolateral nucleus of thalamus. And there are other pathways which you don't need to remember: spinotectal, spino-olivary, and spino-reticular. These are not important. But what is important, again, how can we localize based on this pathway? So I'll give you an example. If somebody has got sensory deficit in the glove and stocking area, what is the problem? Immediately, if they tell, that's where I have got problem, what would you immediately diagnose? There is only one diagnosis: peripheral neuropathy. Okay. What is the commonest cause? Diabetes. Okay. Or metabolic syndrome. Okay, that's one. Second, somebody has got problem with loss of sensation below certain level in the tummy, for example. Where is the problem? Again, in the spinal cord. Okay, somebody has got all four limbs, no cranial nerve sign. It's in the this is cervical level. If they have got loss of sensation along with other cranial nerve, then immediately it's in the brainstem. And if it is in the one side, it could be anywhere between. Okay. The other thing, before I finish the ascending system, we should be aware about the trigeminal system. Okay. From the face, because what we have talked is up to this, we didn't mention about face. Who carries the sensation in the face? Trigeminal nerve. Where do they go and relay? Where is the relay center for the, where is the nucleus of trigeminal? Sensory nucleus of trigeminal?
Throughout the brainstem.
Throughout the brainstem. Just to recap. We got any days? Sorry, I'll use one of these masks. Happy face. Okay, normal sensation is going. Ophthalmic, maxillary, mandibular. So eventually they will go where? In the brainstem. And the nucleus of trigeminal is present throughout the brainstem, as Chelsea has rightly said. So what are the nucleus of the brainstem for trigeminal? Spinal part. What they will receive? All the pain and temperature sensation from this side of the face. Okay. What will the principal sensory nucleus of trigeminal in the pons will receive? Fine touch. And the mesencephalic part, which is in the midbrain, will receive proprioception. So then they will, all these fiber will cross, and eventually it is called trigeminal lemniscus. Where do they relay? In, all the sensory information has to relay in thalamus. So where do they relay? Ventroposteromedial nucleus of thalamus. I'll go through the thalamus. So they will relay in the ventroposteromedial nucleus, and then they will go to the cortex. Is that clear? Okay. So that's how we have discussed before. If somebody has got pain and temperature loss, but all the other modalities are intact, so that means it has to be the spinal nucleus of trigeminal. If they have got only fine touch affected, all the other modalities are intact, it has to be in the pons. Similarly, if the proprioception is affected, all other modalities are intact, it's in the midbrain. Is that clear? So that's how we, that's in short the ascending pathway and how we localize using this knowledge. Okay, thank you.